Hello, I'm Joya Delgado Harris of the American Cancer Society, and I'm pleased to moderate a very special panel aimed to provide women an overall understanding of how we can take control of our breast health. Joining me are Dr. Richard Winder, Chief Cancer Control Officer of the American Cancer Society, and Dr. Lisa Newman, Director of the Breast Oncology Program at Henry Ford Health System and longtime Society volunteer leader. Drs. Winder and Newman will be addressing some of the most commonly asked questions regarding breast cancer screening and what it means to different women. And we're also pleased to have with us Lauren Jarrell, Samantha Elmore, and Ginger Krawick, who will be asking those questions most important to them. So let's dive right in, shall we? Dr. Winder, the Society updated its breast cancer screening guideline for women at average risk of developing the disease. Can you give a brief description?
First, this is a very strong statement about the value of screening mammography, actually showing that its value may have been underestimated in some of the recent research. Second, the discussion about screening mammography should begin around age 40, and women 40 to 44 should have the opportunity to start screening during that interval. But by age 45, if a woman has not already started, we recommend that all women begin screening every year, 45 till 55. And the key to that 55 age is really menopause. We use the age 55 as a marker at the age by which almost all women have reached menopause. After menopause, women can transition to being screened every other year, although we do give the option for women to continue annual screening and a decision with their clinician. Very importantly, we recommend that women keep screening as long as they're well, healthy, and have at least a 10-year life expectancy. And we give some guidance to clinicians in the document itself about how they know if a woman is likely to have 10 years of healthy life in front of her. So that's the key. We clarified that mammography holds the key to early detection, not clinical breast exam or self-exam. We didn't revisit self-exam, but that's part of a pre-existing guideline. So the key is screening mammography according to those guidelines.
But I've known and lost several friends that were diagnosed prior to even turning 40. So why aren't we suggesting that women get screened as early as their 20s or 30s?
Breast cancer can occur at any age. However, the risk, as Dr. Winder was mentioning, definitely rises pretty steadily as we get older. So it's a significant risk in our 40s. It's an even higher risk in our 50s and in ages beyond the change of life, beyond the menopause. And mammograms will therefore be more likely to detect a problem, a significant issue like an early stage breast cancer in women who are older. If we commit the youngest women, the women in their 20s and 30s, to getting routine screening mammogram at regular intervals, we then have to be concerned about the risks of unnecessary radiation exposure to this very young breast tissue, which can be harmful. And we have to worry about the risks of false positive or false alarm findings on these mammograms that may actually end up outweighing the very small likelihood of identifying a breast cancer in a very young woman.
Dr. Newman, Dr. Newman, earlier you mentioned something about a false positive. What exactly is that?
Yeah. So that's a great question, Samantha. It is critical that we clarify the terminology. When we talk about a false positive on a mammogram, we're basically talking about something that turns out to be a false alarm. Anytime an abnormality is detected on a mammogram, We have to then work it up to figure out whether or not that abnormality is a cancerous problem or a benign non-cancerous problem. Because sometimes totally non-cancerous fibrocystic changes will show up as abnormalities on the mammogram. The only way we can distinguish whether or not an abnormality is a cancer is by doing other studies. Sometimes this means that the woman has to go through additional compression views, magnification views, which can be more uncomfortable. Sometimes a woman has to have breast ultrasound imaging. Sometimes she has to undergo an actual biopsy to confirm exactly what that abnormality represents. If the abnormality turns out to be non-cancerous, we call that original abnormality on the mammogram a false positive. So a false positive does not mean that we're finding a cancer that isn't really a cancer. It just means that we had to work up an abnormality that turned out to not be a cancer.
I'd be happy to start us off, Joya, because this is a topic that's really near and dear to me. My question is, why do organizations, including the American Cancer Society, no longer recommend breast self-exams?
Such a good point, because I have friends and family members who've told me that they felt like they were alive because they found a lump through a self-breast exam. So why the change?
So a couple great points, and these are questions that we've been asked quite a bit, of course, since the guideline, and it's interesting because this particular guideline did not address self-breast exam uniquely. In fact, the American Cancer Society has not recommended that clinicians instruct women in monthly systematic self-breast exam, and there's a subtle difference there, for quite a few years. And no major organization does recommend this instruction in periodic, regular monthly self-breast exam. And the reason for this is pretty straightforward. There were some huge clinical trials, mainly done not in the United States because it would have been hard to do that in the United States where self-breast exam was already very common. So they're done in other countries that compared a huge number of women who were instructed to do monthly self-breast exam to women who were not instructed. And there were no differences in any of the important outcomes around breast cancer. So that's what led to organizations withdrawing any recommendation for this instruction in self-breast exam. That is somewhat different than asking the question, has performing self-breast exam helped women occasionally? Have they found something that the outcome changed because they found it a little bit earlier? And we suspect there are women who, for whom that does apply. So there are really a couple of key points. The most important is that the majority of breast cancers to this day are still found by the woman herself. So if a woman feels, notices, sees something that's a little bit different than what she is used to seeing or feeling, or she needs to not hesitate. Bring that to the attention of a clinician right away. And we do hear stories of women who think they feel a change and then they wait months and months to convince themselves. And we're encouraging women, you don't have to solve that problem yourself. Most of these are not cancer, but come bring it to the attention of a clinician. Check it out together and get that question answered right away. So we've recommended what we call awareness, that women be aware of what their breasts usually feel like and usually look like. And that awareness is developed in the course of everyday life. Washing, bathing, dressing, looking in a mirror. So I had women come up to me after the guideline and said, I had inflammatory breast cancer. That doesn't present with a mass. You see a redness, a pinkness of the breast. That, again, it's not an infection. You have to get that checked out right away. So there are women who feel more comfortable doing that periodic breast self-exam. And, we would not encourage a woman who feels reassured by that to stop. But it is important to realize that feeling a lump is a different stage of cancer than finding it on a mammogram before there's a lump. And that's why mammography still holds the key to a truly early detection where the outcome actually can be improved because we found it before a lump actually appeared.
If I'm having lunch or coffee with a girlfriend, can you give me just that one way to explain, like really briefly, like why is the society no longer recommending clinical breast exams?
So thanks for bringing it up, and we'll see if we can help give that easy answer. Dr. Newman and I were talking about one of the challenges is that these decisions were the result of years of research, and lots of synthesis of information. And the challenge to communicate it briefly is one we're all going to keep grappling with. So thanks for giving me another shot. So a couple of things. First of all, people have to understand what a clinical breast exam is. And that's the exam that's usually performed annually at the time of a routine physical exam if someone's doing that, or frankly opportunistically when a woman comes in for another reason. But you take the advantage of that opportunity to do a clinical breast exam, and that's an exam by a professional, by a health professional. And again, in a way, this was a fairly straightforward decision on the part of the guideline committee because they looked at all of the data that's accumulated over many years through all sorts of research to see if adding clinical breast exam to mammography lowered the mortality rates from breast cancer. And the answer is pretty straightforward. We really saw virtually no effect of adding clinical breast exam to mammography. So one of the points that I've made before and reiterate is just to understand what we're able to do with mammography. Mammography is able to find that breast cancer at a truly earlier point in the cancer's natural history before it's large enough that it can be felt either by a clinician or by the patient. One of the other realities of clinical breast exam is even the studies that were done. In the research studies, these clinicians were really taught to take their time, put a lot of emphasis in it, have a very systematic approach. And just realistically, I won't say fortunately or unfortunately, just realistically, most of the clinical breast exams that have occurred in the course of routine care didn't really follow that level of time investment and kind of systematic approach. Bottom line, though, was that the research did not show the mortality benefit. And one of the things that has been happening in this country is that people said, well, you can't afford a mammogram, or you're uninsured, so we'll do a clinical breast exam. That's a good replacement. One of the messages of this guideline is your job as a clinician should be to do everything you can to help that woman get a mammogram. That's really where the investment of extra effort